Good morning, sir. Ladies and gentlemen. I think I should not take much time between the learned speaker who has come from our distance and very distinguished delegates. The topic is so important. I think it hardly needs any further introduction because this is the essence. Somebody has summarized history taking if you have 100% total. 60 to 70% can be scored only by history. Investigation has only 10%. Super special investigation hardly 5 to 10%. Even after calculating everything, 5% still remains nothing. Nobody knows what is there. It's in the hands of God or the good luck of the patient or your good luck. Nobody knows. So even if you meticulously calculate, the more than 50 to 60% simply good history taking, be spending time on the patient as per the traditions which were set down by Ayurveda and others. If you go down, I think you will be gained. So with these few remarks, I very humbly request the worthy speaker to please deliver the document.
Members of the audience, friends and some juniors, it's always a feeling of homecoming when you come to speak or attend an Iacmcon, and that is exactly what we are having since yesterday. And I thank Dr. Luba, Dr. Soni and the entire team for organizing this feast once again for clinical medicine. We live in a consumerist society. And in a consumerist society, this is what happens. People come to us at times of need. We are equated with God. And once things are over, we are either forgotten or slighted or possibly both. And how do we get across this mess that we find our profession to be in? We need something which acts more often than we look at our family. This is what happens to the concept of doctor-patient interaction. We don't have the time to talk to our patients and things go awry right from the beginning. Yesterday there was such a wonderful discussion and I was feeling a little worried because 50% of what I planned to say was said yesterday by two people. Number one, the guest of honor at the scientific inauguration, who gave examples, and I have similar examples, and the other was a speaker from Chandigarh who dwelled on the medical legal aspects. And I wish to draw your attention to the last line of this projection, which says that the majority of malpractice suits that you and I are worried about, Dr. Arya was just now pointing out that we are becoming defensive practitioners of medicine, arise because of poor communication, not because of our professional incompetence. To honor the ethos of the association, I have collected a couple of cases. Trust me, each of these cases are real cases from real examples. Some of the investigations are restructured for the purpose of the presentation. So this was a newly married lady who was having pain abdomen and recurrent hematemesis. She was carried across to several doctors, and basically we had a harassed husband and a harassed in-laws syndrome because there was no diagnosis. The patient continued to suffer. She refused to undergo an endoscopy. One evening she fainted. Local GP came in, couldn't elucidate. A very senior person from our city was called in, and house visits or home visits are now a rarity in our profession. So this very senior person went, and the person had a one-to-one with the patient. The family was worried what was the doctor doing with the lady for such a long period of time. Those were the times when a doctor could afford to be with the lady for 15-20 minutes, not now. And believe me, when the consultant came out, this was the diagnosis. The lady had a history suggestive of pica. She had depression, and following her wedding, she was biting and chewing on lipsticks. And that was what was coming out as hematemesis. So this was almost anecdotal, but it's a real life story. This comes from one of my juniors from medical college. I wish Munchanda madam was here. She knows the person concerned. This guy was an internee at Calcutta Medical College. He had vomiting, feverishness, malaise, non-specific symptoms, PPI, domperidone. His father was also a doctor, so he was taken to a gastroenterologist, endoscopy, NAD, PPI, admitted, NPM, IV fluids, this, that. Month later, he developed paraparesis. And believe me, till date, he is a doctor, he is a consultant, but he walks with a crutch because the early diagnosis of tuberculous meningitis was missed. And the first doctor who saw this patient was a gastroenterologist. So that was the story of one of my juniors and students. This was a 12-year-old girl. Again, her father is personally known to us. So she was brought to my OPD at CNMC, Calcutta National Medical College, and she was having this vomiting for a long period of time. We actually didn't get anything, but we saw asymmetric pupils. And it was such an easy diagnosis, she had an unnoticed subdural hemorrhage. But then she was moving around with her headache and vomiting for quite some time without having a simple diagnosis. Interestingly, it is said that in a clinician's lifetime of professional practice, he spends the maximum amount of time interacting with patients. And I think this is more applicable to physicians rather than surgeons who has the time to operate when the patient is not talking. So this history taking is possibly the most prevalent part of our professional activities in the lifetime of a clinician. And how does it contribute? As rightly pointed out by the chairperson, there have been several publications and several medical education research on this subject. A very simple study was conducted on medical students, and they were given 4 cases. A case of hypothyroidism, infectious mononucleosis, migraine and carpal tunnel syndrome, which are not important. What was tried to see was what was the percentage of diagnosis that could be arrived at the end of history taking, at the end of physical examination, and at the end of lab reports, once the lab reports were supplied. And as the chairperson was on the dot, 70% of the diagnosis could be arrived at by a meticulous and proper history taking by undergraduate students, which I think you and I all follow. The moment the case is given for a UG class, the history is ready, and you can actually take the history from the UG people and put it down on the PhD. Another young lady had abdominal pain, unremarkable exams, unremarkable investigations, several hospitals. Yesterday, again the inaugurator pointed out about a case of porphyria. So this patient, we were planning urinary porphyrogen, thinking of porphyria, and later we jumped to the history of her mother working in a paint factory, and she was accompanying her mother day in and day out, and possibly this was lead toxicity leading to ectodermy. So I don't have the audacity of talking about the merits of history taking to this learned audience. We all know the traditional history, what history should incorporate. The problem or the point is that we often tend to miss the facets of history which can lead to a very plausible diagnosis. We forget history about allergies, we forget history about drug reactions, we forget history about pets, we forget history about exposure to dust at home. We ask about smoking and alcohol, and I will tell you that smoking and alcohol may not be inconvenient in all cases. And we forget history of sexual preferences. I promised you I will not go into a didactic presentation of what should and what should not our history contain. But then, for the purpose of juniors, and there are very, very few juniors in the morning, thanks to the banquet yesterday. But then, we need to follow some basic algorithm when we get into history taking. In India, we don't have this practice of introducing ourselves or telling our name to the patient, but we need to open the interview with anything which we can develop as our own style, but not what is your problem. The first question cannot be what is your chief complaint. We need something which can be termed as ice-breaking when you open an interview. Number 2, we need to give the patient time to talk and to talk in his own language, provided we try to steer the course of the story in the relevant professional direction. So patient must be allowed to talk because we tend to dictate what the patient has to say. We feel that the patient has cough and fever, so it has to be pneumonia, so patient must say that khasi ka sab balgam aa raha hai. But the point is, let the patient say, and patient might say things which are interesting, which are not expectant. Patient's perspectives are very important because a patient might have expectations which are unrealistic expectations. We have clinical examination as part of the clinical interaction with the patient, and during the clinical examination, we should learn to communicate and talk to the patient. Very often the patient doesn't know what is happening with his body. We pinch him, we palpate him, we look at his blood pressure. Patient is very eager to know what is my blood pressure, but the doctor has on a straight face and doesn't talk to the patient during the examination. So that possibly increases the blood pressure. So basically we need to communicate during the clinical examination. Last but not the least, you need to negotiate and agree on a plan, and the best example that comes to my mind is the issue of diabetes management. You cannot write insulin, you cannot write admission, you cannot write IV fluids without talking to the patient. You need to talk to the patient, whether he is available, if it's not an emergency, whether his son has an examination coming, whether he will come back after 1 month or after 7 days, is all aspects of negotiation. So basically we need to talk, we need to be professional, we need to be short, we cannot waste our time the whole day with the patient, but at the same time we can and incorporate all these in our day-to-day practice. Last but not the least, the closure of the interview. The closure is extremely important because it is at this point of time that you might elicit the issues, you might elicit information that were yet untold or yet undiscovered. And when the patient leaves the doctor's chamber, he is anxious to know what is the plan of follow-up, what happens if I fall sick tomorrow once again. So there has to be some sort of follow-up assurance and some sort of plan for the near future. So basically this looks complex, but believe me, when we were into the teachers training program at our Department of Health and Family Welfare Government of West Bengal, we learned the concept of internalization. And basically what does internalization mean? A pathologist can be performing 100 FNSs a day, and every time the pathologist doesn't remember that I need to tell the patient that ek sui bhokega, lag sakta hai thoda, zyada nahi lagega, daro mat. That is internalized within the pathologist, and he or she tells that to each patient. So we can also internalize this concept of patient interaction. And this is much simpler, but basically we need to listen, clarify, question and summarize. And whose business it is to summarize? I think I tell this on my daily rounds. When we see a patient, the PG presents a case, maybe the house staff or the internee tells us the blood pressure, we advise the tests and drugs. But at the end of before we leave that bed, there has to be a summary sentence to the family. What is the doctor thinking? What is the plan of action? What is tomorrow's plan of action? One summary statement has to be there at the end of patient interaction. I think we have all forgotten about how to construct a family tree. It is so important in history taking. So many diseases will come up. And again, during the interview process, your examination begins right from the point the patient enters. So there are so many things that can be revealing to you, which the patient might not be telling. This patient might be coming with a cough, and he might not be telling that he has an artificial limb. You need to assess the mood and motivation and the level of anxiety, the level of depression. Extremely important to look for clinical clues. And what are the clinical clues? Which is the clinical clue here? There are multiple prick sites. So these are the people who are in our society, and you might not elicit history from all of them. So you have to look for what is there, and again what is not there. So these are things which come from history taking and a good observation. Yesterday somebody was telling us that we need to behave like Sherlock Holmes, and actually we need to behave like Sherlock Holmes. I will not detail this case. Simple story. A pilgrim who came to the Ganga Sagar Mela was suffering from palpitation for years, and then he came to us, and then we did the ECG, and he was having flutter fibrillation, blah blah blah. Point is, nobody lifted his beard, and there was a nodular goiter. The thyrotoxicosis was giving rise to palpitations. And he was going around all this while with palpitations. So, lot of these come. This was such an interest. This was presented by one of my colleagues, Professor Shanghai Mondal. He presented it in one of the clinical medicines conferences of West Bengal. Basically, postprandial chest pain, nothing anywhere. And then the endoscope was put in, and there was a broken denture in the esophagus. Believe me. So this is, and nobody examined the esophagus and examined the denture, that the denture was broken, and possibly the patient thought that it was important to tell the doctor. So you need to ask. The patient doesn't have the responsibility of diagnosis. You have the responsibility of diagnosis. This patient was very unfortunate. He made news headlines in West Bengal for all the wrong reasons. I happened to be in this hospital at that point of time. Possibly people will remember. This girl had a road traffic accident injury, admitted under plastic surgery, perfect repair, immediate reconstructive surgery was performed, and then she died the next day. And the media went mad at the hospital and the medical profession, and then autopsy was performed, and then it was found that apart from the degloving injury on the shoulder, she also had a blunt from abdomen, and she bled internally, and possibly plastic surgery did not examine the abdomen. So that is what happens in, again, the super specialty buck. Extremely interesting. Trust me, this is a real life story. This was when ages ago I was at medical college. So on the post-admission day, this case was presented as, sir, we have a patient with Takayasu arthritis. Why Takayasu arthritis? And you don't diagnose Takayasu arthritis on an emergency admission day. You diagnose it after 7 days. So anyway, so this young guy told me, so why? Because she has pulse business. And basically there was extreme bradycardia. Nobody had the time to wait for 1 whole minute and touch the pulse and count the pulse. To touch the pulse was not there, so it was Takayasu arthritis. When it was complete heart block, life-threatening. I will not dwell on this case because of shortage of time, but then this is any juniors? Prolonged fever, high leukocyte count. This was a cigarette burn. Classically a cigarette burn scar of scrub typhus. Again, this comes from a distant relative of mine. This guy was having a normal life, normal activities, everything normal, except for the fact that he was having urinary incontinence both at school and at home. And then he was taken to a very renowned pediatric surgeon. And believe me, within 2 minutes, sir diagnosed that this was a case of meningomyelocele. So there was a dimple over the buttocks, and it was a clinical diagnosis. It was worked up, he was operated, but then he was suffering from urinary incontinence for such a prolonged period of time, and it was essentially a clinical diagnosis. So this again comes from my present hospital. Prolonged fever, post-sedation, fever doesn't go down. We don't know why there is fever, and you turn the lady over, and you see there is an infected bed sore. We forget to look at the feet of our patients, leave aside examine the pulses of a diabetic person, which is absolutely crucial. This was a lady who was young lady who was admitted under us, fever, ICTC, query TB, sent up home because no evidence, and then she came back again, and on the second admission we discovered that there was a sinus over the sternum, and this was a tuberculous sinus. My colleagues are around, and over the last couple of months, we are, in addition to our medicine duties, we are attending the neurology OPD because of paucity of neurologists at our hospital. And this comes from the neuro OPD of our hospital, where this boy with a breakthrough seizures on anti-epileptic drugs, basically a diagnosis of tuberous sclerosis. So this is all clinics. And then I cannot resist the temptation of showing you 1 or 2 HIV cases, and then both are inactive. But any cases, who is on what? The left one is on stamidine because of extreme lipodystrophy, and the right one is on zidovudine because of nail pigmentation. I think the nail pigmentation doesn't come very well. But you look at a patient and you can see so many things, and you can actually play the role of God. So basically, we need to look at the peripheries. The right-hand patient is presently admitted under us in our unit, and believe me, such extensive psoriasis, we missed it for the first 2 days. We run an extremely overcrowded ward. We don't have a place to walk in our ward. This was a diabetic person who was admitted and with nephropathy. But for 2 days, the visiting and the resident did not have the time to remove the sheet and examine the bed. This was on the 3rd day of admission that we found it extensive psoriasis. And same out here. Again, clinical diagnosis, fever and pallor. This was basically a cutaneous T-cell lymphoma. So this was lymphomatous deposits. Professor Shobhan বিশ্বাস will probably recognize this. This was during the dengue epidemic. This was at Calcutta National Medical College. 50% of the patients were under mosquito nets. And then everybody who had fever was being suspected as dengue, which is true, which is an epidemic situation. But then the left-hand person actually had dengue with hemorrhagic manifestations. As you can see, the right-hand lady was having vasculitis. So even if you have purpura, you need to palpate and you need to see whether it's a hemorrhagic purpura or whether it's a vasculitic eruption. Again, this gentleman admitted last week, pedal edema, alcoholic. It takes 2 seconds for the resident to tell you, sir, you have alcoholic liver disease. CLD, chronic alcoholic liver disease. Very good. The chest X-ray comes out from his bag. Sir, this is alcoholic cardiomyopathy. Dilated cardiomyopathy in alcoholic. Believe me, nobody auscultated. Huge, severe aortic regurgitation murmur. You can diagnose it from a kilometer, but then you need to put the stethoscope, and rather than blaming the alcohol or the smoking for everything around and about. Good clinics leads to right test. This patient we actually saw at Calcutta. He was referred from North Bengal at that point of time, and there was nothing. There was basically a non-specific prolonged fever, and the clinician in North Bengal had the good, he was astute clinician who found vertebral tenderness, and only one test was done, and that was an MR, which showed up epidural abscess. Again, this patient, the boy was admitted under us, I think, a month or 2 ago, and basically he had lower limb weakness, but my resident was again good enough to appreciate that pulses were weak in the lower limbs. And then we did this CT, and what came out was a large granulomatous lesion which was encasing the aorta and possibly compromising blood supply to the lower limbs. There have been several publications, and we don't have the time to go into all these, but then there are some diseases for which you actually need investigations. We cannot underestimate investigations. Look at congestive heart failure. VS is vital signs, HX is history, PE is physical examination, lab tests and ancillary tests. So for congestive heart failure, you need vital signs, you need history, you need physical examination. But if it is diabetes, all you need is a lab test. If it is hypercholesterolemia, you need lab tests. For hypertension, again you go back to vital signs. So basically the purpose of showing you is that it's a conglomeration of history, physical examination and lab tests. We often do not carry a torch, we often do not look inside the oral cavity. But believe me, the oral cavity can be extremely revealing. This is a photograph I borrowed from my wife. And there is large papillomatosis in the posterior pharyngeal wall. So you need to look into the oral cavity. And trust me, once you get into this habit, it doesn't take too much of a time to have an examination from the head to the feet. I again will not get into the details because of shortage of time. This HIV positive person had progressive weight loss, abdominal pain, vomiting, prolonged history. And you know, when HIV patients have weight loss, people think it's HIV, weight loss to Hanayi. And then we palpated a large abdominal lump. This was one of our landmark cases at that time when we were initially into the field of domain of HIV. Bariums were revealed a gastric outlet obstruction, huge mesenteric lymphadenopathy. That was the time when HIV surgeries were really rare, and the exploratory laparoscopy was done, extensive mesenteric lymph nodes, and we diagnosed a case of diffuse high-grade B-cell lymphoma in a HIV positive person. To wind up the presentation on history and clinical examination, we cannot get back to the concept of OSCE, which over the last 25 to 35 years have made its mark on the professional assessment of our residents, and there are several things which are assessed in the OSCE, and it has become extremely a valid test. But look at the bottom, there are several facets which cannot be assessed, and as Professor Iyer was talking before me, there are things which we need to integrate into ourselves which can never be assessed at the examination or by any malpractice suits. We need to train our students, and we know, and all of us who are examiners will agree, that when you go to another college to take an examination, you underline the feeling that people are more into investigations, more into having fancy diagnosis, rather than having hardcore history and physical examination. And that is why we have standardized patients in UK and US, in the Western world, where You have a patient who is a person who is trained to behave as a patient so that you can learn on him. And today, sir, one more minute. And today you have the concept of a virtual patient, which is basically a computer animated patient. You can act, it's like a video game, and you can learn, you can practice, you can repeat, and you have virtual patients of various diseases. So this is a step forward from the standardized patients. So here you can see you can have a person sitting and interacting. It's almost like a chat room, and you can talk to a virtual patient, interact with him, and find out the last part is whether clinical medicine is antagonistic to evidence-based medicine, because we all dwell in the era of evidence-based medicine. It is important to understand that evidence-based medicine is basically medicine generated from statistics, and statistics alone cannot cure or handle an individual. So you need evidence-based medicine, but you also need the person-based medicine or individual medicine, and individual medicine is clinical medicine. This is a very strong editorial which came out almost more than 10 years back, and basically it was a meta-analysis of several studies in which they tried to find out what was the contribution of history taking, physical examination and investigations to reach a particular diagnosis. And you can see a grouping, more than 70% of the diagnosis generally comes from history taking. You need not have a pinpoint diagnosis. In our department, in our hospital, we are now trying to follow the ICD code. And any of you who have used that will understand it's not very easy because it has a lot of permutations and combinations. But at least you can block a disease to a particular subgroup or a particular system from the history, and thereby have a focused physical examination and investigations. Possibly the penultimate slide, we also have publications from India. This is 15 years old, as you can see, and this basically echoes what everybody else was telling, that more than 70% of the diagnosis, this is from South India, can be achieved by history taking. So basically, history taking and physical examination are the most powerful diagnostic tools that we have ever come across. And I remember a leading cardiologist came from Bombay. He was attached to the Bombay hospital, and he was telling us a story once. He told us that the hospital administration had asked him, "We have allocated so much, 10 lakhs of rupees for your department. What more investigation do you want from your department?" And he responded, "Sir, I have all investigation facilities, all technological advances in my department. I need one more trained nurse who can tell me how many times in the night my patient has vomited or how many times he has had a syncopal attack." We celebrate clinics our own way. We at IAC West Bengal has a very strong clinical medicine following, and trust me, you are welcome to join us at our state conference in West Bengal. You will be happy to see what a good bunch of clinicians and clinicians with inverted commas we have created over the last couple of years. Thank you.
So, it was an excellent presentation from Professor Depanjan, who is an excellent